and that is something to consider when choosing one of these modalities to assist in respiratory failure. So we've got a few cases to go through, so we'll talk about them and we'll see how we get on. So case 1, 72 years old gentleman who presented to ED three days worth of shortness of breath and cough. Saturation was 85%, and as the medical officer, you've been asked to review. So how would you review? How would you proceed from here? I don't know if we can we let the audience participate and tell us how
so
they
can write it on the chat box if you want.
Oh, yes,
we can
please.
wait for another 1 minute and they can write it on the chat box.
Yes.
Okay. So please write it on the chat box. So what are the main things to be considered in this particular case?
Yeah, chat.
Yes, we do have one answer.
Okay. I can't open, yes. Curb 65 X-ray oxygen support. Yes, okay, yeah, thank you. It's a good start. Generally, I tend to tell my my trainees is the answer to any question in clinical medicine is ABC. So, in any patient who we see in an acute situation, always proceed through ABCD approach. So A is for airway, and in this case, the airway is patent. B is for breathing. We assess the breathing of the patient. So his respiratory rate was 32. Patient examination has revealed that the patient is wheezy all over chest. C is for cardiovascular. Patient is warm. The blood pressure of 150 over 70 millimeters of mercury, heart rate of 115 beats per minute. And D is for disability. So the patient GCS is 15 out of 15. E is for exposure. Temperature 37.9 degrees. The patient's BMI is 18.2. So what do you do next? Please type something in the chat.
Okay. So after A, B, C, D, E process, what is the next step you would like to take? We'll give them under 30 seconds.
Oxygen. Yes. Yeah, good start. Yes, thank you very much. Yes, we treat the patient and also investigate further as we go along. So obviously this patient is unwell. The main problem here seems to be that he's hypertachypneic and wheezy with a highish temperature and a low BMI. So let's see what we've got next. So this patient had a blood gas and the pH have shown that is 7.35 with a PO2 7.3, which is equivalent kilopascals, equivalent of 55 millimeters of mercury. PCO2 for this patient is 9.2, which is equivalent of 69 millimeters of mercury. Bicarbonate is 30.2 and the lactate of 2.1. And this is a chest X-ray. So what do you think? What's your diagnosis?
Please write your diagnosis on the chat box. COPD.
Respiratory acidosis. Yes, you're right. Just one more word to make it accurate, which is compensated. Compensated respiratory acidosis, because the patient is not acidotic, just on the cusp, isn't it? 7.35. Okay. Yeah, we're getting there. And good. What's the underlying mechanism? What's the disease here? Look at the X-ray. Does this look normal? The X-ray. Yes, exactly. Thank you.
Pneumonia.
Yes, pneumonia is perhaps. I can't see any consolidation in this chest X-ray, so it's unlikely to be a pneumonia. Though it is possible, but it's unlikely because we cannot see any consolidation on a chest X-ray.
Okay,
someone said emphysema.
Yeah, and we have one more answer. BVM.
What that stands for?
What does BVM X-ray is hyperinflated, so air trapping asthma.
Yes, X-ray is hyperinflated indeed, and there is air trapping, but it's not asthma. It is COPD. So the diagnosis here is acute exacerbation of COPD. How would you manage this patient in the first instance? Someone mentioned these things before.
What is the management of this particular case for COPD?
How do you start this management of this patient? So the starting would be oxygen, which one of you mentioned before. Nebulization, yes, absolutely. So usually in this sort of situation, guidelines would suggest that the use of oxygen, controlled oxygen delivery, with a set to aim for a peripheral oxygen saturation 88 to 92%. Because as you know, some of the COPD patients, particularly the chronic retainers of CO2, will be very sensitive to oxygen.
There are a lot of answers for this particular management.
Yes, good. So we'll continue with the oxygen to aim for 88 to 92. The idea behind that is that too much oxygen can result in suppression of breathing in COPD patients, and also can result in constriction of the pulmonary vessels, and that can result in further CO2 retention. Nebulized beta agonist and anticholinergics, yes, and also systemic steroids, as you quite rightly mentioned. Okay, then you go in half an hour later, and this is the patient situation. So respiratory rate is 37, SATS is 89, GCS remains the same, and he is this is his blood gas. What do we think, and what will you do next?
So what will be our next step? So after 30 minutes, we are entering and we are seeing the same patient. BiPAP to flash out CO2. NIV support.
Yes, exactly right. So clearly, this patient did not benefit from the medical management that we started, oxygen, etc., and nebulizers, and his CO2 is increasing, and he's now become acidotic, and he's decompensated. His compensation has failed to maintain normal pH. Yes, we would start NIV in this patient. Usually, the guidelines suggest that we start with an EPAP of 3 centimeters of water and an IPAP of 15 centimeters of water, and the lowest oxygen fraction that you can use in order to maintain the 88 to 92 saturation. The idea behind this low EPAP is what we've mentioned before, is that the EPAP may result in further CO2 retention. And also, these patients are, many of them, or some of them at least, will be gas trapping. And they will have what we call auto-PEEP, breath stacking, so they don't exhale fully. And if you put a barrier in the form of EPAP against their exhalation, this may worsen their gas trapping and the CO2 retention, and can result in cardiovascular collapse. This is usually due to increased intrathoracic pressure, and then will reduce the venous return and lowering stroke volume, resulting in low blood pressure. An IPAP of 15 is a good starting point for this patient to improve their alveolar ventilation and minute volume. In the next instance, you would continue to monitor this patient blood gases and see what their PCO2 is like and the pH, and you would titrate and increase the IPAP in order to reach a normal or a near normal PCO2. Great. Okay. So you come in an hour later, and this is your patient. So respiratory rate 37, SATS 89, GCS has dropped a bit to 13, and this is his gases. What do you do now?
There's one answer, early invasive.
Okay, yes, good. I assume by that you mean invasive ventilation? Or intubation, mechanical ventilation? So this patient does not seem to have responded. Increased expiratory time, yes, maybe. MV, mechanical ventilation, maybe. We'll talk about that in a second. But let's just think about what's happening here. So these patients become more acidotic despite NIV. GCS dropped 2 points. Oxygenation is okay for a patient like this, but the PCO2 is 10.3, so it's progressively getting worse. And now his acidosis is much worse. So we've tried to titrate the IPAP and increase the IPAP, but this is not working. So would you intubate this patient? In order to, NIV looks like it has failed. Patient is deteriorating. If you leave it any longer, they may arrest. So would you proceed to intubation? Some said yes. So, okay, let's think about it a bit more.
Okay, change NIV settings.
Okay, we've tried that. Unfortunately, didn't respond.
Okay, no response. So what next?
Yes, so intubation is, before you intubate this patient, what would you consider? Would you intubate anyone in this sort of situation? Or would you have to think carefully about who would you intubate and what were the factors that you would consider before going towards mechanical ventilation and ICU stay for a patient like this? Any ideas? Shout out anything, doesn't matter, right or wrong. We're just discussing.
Exactly, please write it on the chat box.
Okay, increase respiratory rate and PEEP, increase IPAP. Yes.
Difficult to wean off.
Yes, good point. Maybe. So COPD patients are actually a difficult cohort to decide if you would proceed to endotracheal intubation and ventilation. Some studies have shown that they benefit from short period on a ventilator. But as you know, their outcome generally of this, someone who's got COPD, severe COPD to the point that they failed NIV, and they got a BMI of 18, which also is associated with worse outcome in this cohort. So what I would consider before I decide to whether to intubate this patient or not is first comorbidities. So what other diseases does the patient have along his COPD, heart failure, liver failure, or other diseases that may influence this? The more comorbidities the patient have, the less likely that they benefit from endotracheal intubation and mechanical ventilation. And as someone said, it is going to be very difficult to take them off the mechanical ventilation. Another thing to consider is exercise capacity. How much the way I would assess this is how far can the patient walk? If they can walk a fair distance, if they can go up one flight of stairs, this is usually means that they have got reasonable exercise capacity. Another thing to consider is reversibility. So what is going on here that has resulted in this patient decompensating, COPD decompensating and resulting in this picture? Is a reversible element to the disease, or is it a deterioration of an ongoing chronic end-stage disease? So if the patient has got a pneumonia or a viral infection, or have reacted to an allergen, then there may be an element of reversibility here, and this may influence your decision to intubate them, because there is something you can treat and you can bring the patient back to their baseline and take them off the ventilator after a short period. But if there is no reversibility, and this seems to be deterioration of a chronic condition to the point of that it becomes end stage, then intubating this patient is not going to be of benefit, and the patient will suffer long in ICU and will result in not a very nice death. Another thing is the rehab potential of this patient. As you know, patients who are admitted to ICU, even for a day or two, particularly in this kind of situation with a low BMI, they lose a lot of their muscle mass, and that will result in them becoming very weak after their ICU stay and it will take a longer time for them to rehabilitate and be able to go to their previous level of exercise capacity. So this is also another factor to consider before intubating this patient. And also patient wishes. Some patients may wish not to be intubated and go to ICU. And if that's their wishes, then we respect their wishes and would not proceed to mechanical ventilation with them, and maybe proceed to consider palliation. Any questions about this? Anything you want to add? Anyone?
Any doubts or any questions? If you have, please write it on the chat box. I'll be taking the questions from there.
Okay, we'll carry on.
Yes.
So this is a second case. A 70-year-old gentleman presented to ED, 3 days worth of shortness of breath and cough, and low saturation. Asked to review. How will you proceed? Sounds like the first one, isn't it?
Right.
What's the answer to any question in clinical medicine? Wait a few seconds.
What do you think? How should we proceed for this particular case?
Yes, check ABC. Thank you. So the airway is patent, breathing, respiratory rate at 35, reduced air entry, patient is warm, blood pressure 150/70 with a heart rate of 115, GCS is 15 out of 15, temperature 39, and the BMI of this patient is 28.2. So just for the sake of time, I will proceed. And this is the patient blood gas and the chest X-ray. So pH 7.26, PO2 7.3, PCO2 of 8.2, bicarb 22, lactate of 3, and this is X-ray. What do you think?
So we have the X-ray, we have the findings. So write LL consolidation.
Yes, thank you. So what do we think is going on here?
Okay. So any more suggestions? Respiratory acidosis?
Yes. So there is consolidation on the chest X-ray. Yeah, there is a respiratory acidosis, not compensated, but to be honest, because the patient is, if it's compensated, then the pH will be normal. But this is not compensated. So diagnosis here is community-acquired pneumonia.
Okay.
How would you manage this patient? What is the first things you would do?
Pneumonia. So community-acquired pneumonia is the diagnosis. So what do you think is the best way of management? Antibiotics? Antibiotics and check TLC? And antibiotics with steroids?
Thank you. Yes, antibiotics is the right answer, but we always think of what's going to kill the patient first, which is hypoxia in this case. So we start with oxygen sets. In this case, we aim for 94 to 98 because the patient is not known to have a respiratory disease. So we'll aim for a higher target of oxygen saturation. The guidelines suggest controlled oxygen delivery with a target of 94 to 98%. Before we get the antibiotics, ideally, we should get a sputum sample for culture sensitivity. If the patient has got a fever, like our patient here, 39 degrees, then I would also obtain samples for blood culture, and antibiotics is the right answer. Ideally, this patient should receive antibiotics within the first hour of presentation to healthcare. And the antibiotics are usually decided by local sensitivities. So depending on your hospital, they will have a policy for antibiotic cover for community-acquired pneumonia until the sensitivities come back of the sputum and the blood cultures. Okay, good. So you come back 1 hour later, and this is your patient. The blood gas. What do you think?
So after 1 hour, when we enter, we see the findings. So what next? NIV?
Okay.
Start on NIV support. Any more suggestions? Okay, so NIV with high PEEP, steroids.
Okay, thank you for the suggestions. So some people mentioned NIV and someone's mentioned steroids. I'll start with the steroids. Steroids are not indicated in this case because there's no underlying COPD as far as we know. Patient is not wheezy, so it's unlikely that this reactive airway disease here, or non-reactive for that matter. So steroids are not indicated, at least at this stage. Someone mentioned NIV. Let's think of why is this patient blood gas looks like this. So the PO2 is low and the PCO2 is high and they're acidotic. Why is the CO2 high? Why are they retaining CO2? Any ideas?
I think he's already given you the hint about CO2. So type 2 respiratory failure.
Personally, I don't like the term type 2 respiratory failure because it indicates that the patient has got COPD. Usually, it's a bit old-fashioned. I prefer the term hypercapnic respiratory failure because it's more descriptive of the situation.
Okay.
And this patient
more suggestions.
Yes, so I can see them.
Might need bronchoscopy to clear the secretions. Then one of the doctors have written COPD and with physiotherapy.
Again, we don't know that this patient has got COPD, so it's unlikely that they're gonna that they've got COPD at the age of 72 with a previous. It's possible, but it's less likely. Physiotherapy, yes, but the patient GCS is low, is acidotic. PCO2 is high. What I'm getting at here is that this patient is getting tired and they're not able to breathe out their CO2 or maintain the minute ventilation in order to clear the CO2. So someone mentioned NIV. So would you use NIV or would you go straight away to mechanical ventilation?
Okay. So what do you think, NIV or incubation? NIV. So maximum people are writing NIV. NIV since age factor.
Okay, thank you for these answers. Actually, NIV is contraindicated in this case because this patient is getting tired, and when the patient is getting tired like this, they are at risk of respiratory arrest because they are just about able to expire the CO2, and the pH is deteriorating. And if you leave them like this, even if you put them in NIV, the GCS will continue to drop. They will not be able to cope, and they will arrest. So in a community-acquired pneumonia without COPD, NIV is actually contraindicated, and this patient as the guidelines and clinical practice suggest that intubation is the right course of action here. Age is a factor in intubation, maybe, depending on how, all the factors that we mentioned before, what other comorbidities they have, what is their exercise capacity, because some 72 years old are, they work full time, they play golf on a regular basis, and they have a very active life. So age...
Incubation and suctioning.
Yes, intubation indeed, and that's what we've been saying. So suctioning, yes, that may be helpful. If the patient is not responding and they're getting worse, maybe bronchoscopy and for clearance of retained secretions as well as sampling may be helpful. Okay, for the sake of time, we're just gonna move on. So case 3, you have a 72-year-old gentleman in ICU. 3 days ago, he had a laparotomy, was extubated 2 days ago, and you've been asked to see because the patient's abdomen is distended and they got pain secondary to the operation. And this is the blood gas and the chest X-ray. So what do we think is going on here?
And the X-ray. Pleural infusion or rupture.
Okay, thank you. So the blood gas shows that the patient is acidotic, pH 7.3 with a high CO2, and the PO2 is borderline 8.3, just about acceptable. The chest X-ray shows some pleural effusion, as you mentioned. There are bibasal collapse. There may be consolidation, but we can't see very well. There may be also hematopulmonary edema, which is not very uncommon chest X-ray in patient post-laparotomy, particularly if they are slightly older and they have multiple other comorbidities. Pneumonitis, yes, maybe this patient is aspirating, the abdomen is distended, and they've got pain. So what will you do? How would you manage this patient?
How to manage this particular case is the next question. Please write it on the chat box.
All right, just for the sake of time, we will proceed. So as we do with the ABC, yes, someone said
TLC, culture, and sensitivity blood culture.
Yes, we do all this, absolutely. But as we always do ABC, so we will try to maintain oxygenation of the patient by giving supplemental oxygen, breathing, we'll get to that in a second, circulation, etc. And then obviously we do all the culture. Exactly, thank you, pain relief, yes. It's very important.
Great, Dr. Priyanka. It's a great answer.
Yes. So patients in COPD, in patients who have a post-operative period, pain is a very important issue in their respiratory failure because they have pain in their abdomen or chest. They can't take a deep breath. The basis of the lungs will collapse, and then respiratory failure will set in. This will invite infection, and it becomes a vicious cycle. So let's say we have treated the pain, we give them oxygen. CO2 is not, we've deflated the stomach as much as we can with the rise tube, but the patient is not getting better. Would you use NIV to correct the CO2 or would you intubate them or do nothing?
So again, the last question, that is the management. What will be the answer, NIV or intubation? So we have one answer, intubation. and Dr. Gagan is writing NIV. So maximum people are writing incubation.
Okay, thank you very much. I think there's no right and wrong answer here. I think it depends on the patient and what do you feel you can achieve. In ICU, we have the luxury of one-to-one nursing and a close monitoring, and you are close to the patient. You can start with the less invasive. You can afford to start with the less invasive approach and see how the patient would tolerate NIV. If they would tolerate NIV, are they delirious? Can they tolerate the NIV? Is it effective in their situation? And then if that fails, then you can go straight into intubation. If the patient condition is really advanced and the CO2 retention is high and they're getting tired, then NIV particularly may not be particularly useful in this case, and you would proceed to intubation. So there is no right and wrong answer here, and the guidelines also say that NIV could be used in this situation, but under specialist guidance. So basically, it tells you to do what you think is right, and I think this is the right approach, then, because there's no clear-cut right or wrong answer here. Okay, thank you. So we just quickly overview the guidelines. So the British Thoracic Society and Intensive Care Society of the UK have produced guidelines for the management of hypercapnic respiratory failure in adult using NIV. The guidelines were published in 2016. They are a little bit old now, and they have not been updated, but nonetheless, they are what is used as base for management in the UK, and I think they are still relevant. So indications for NIV mainly is acute hypercapnic respiratory failure. The etiologies that the BTS guidelines suggest are acute exacerbation of COPD, acute on chronic asthma, bronchiectasis, cystic fibrosis, neuromotor diseases such as myasthenia gravis or motor neuron disease, also obesity, hypoventilation. And also the guidelines, as we have suggested that NIV can be used in ICU, but they were non-descriptive of when to use it and how, and it was left to the specialist advice. And again, I think this is the right course of action. So contraindications to the use of NIV, acute asthma is a contraindication, which is if someone in acute severe asthma to the point of retaining CO2 and becoming acidotic, this means that they are getting tired, and they may not be able to maintain their respiratory function. And the guidelines suggest that in this sort of situation, you should proceed straight away to intubation and mechanical ventilation. Same thing for pneumonia, as we have discussed in the case we have presented, and also cardiogenic pulmonary edema. So this is a very busy slide of the algorithm that the British Thoracic Society has suggested to follow in order to guide the management of acute hypercapnic respiratory failure and the use of NIV. So indications, as we said, COPD, neuromuscular disease, and obesity. Basically, if the patient is acidotic with a raised CO2 above 6.5 kilopascals, which is equivalent of around 49 millimeters of mercury, then NIV is indicated. Absolute contraindications are facial problems, such as facial deformities, burns, or fixed upper airway obstruction. Relative contraindications to use of NIV in this cohort is severe acidosis, and the BTS defined that as a pH less than 7.15 or a pH less 7.25 with additional adverse features. Also, if the patient GCS is low, and usually below 8 is the cutoff for contraindication to NIV. I think this is a bit low, but I probably would proceed to intubate patients before they reach a GCS of 4 or 5 in this sort of situation. Confusion, agitation, and cognitive impairment are relative contraindications because patient in this sort of situation does not tend to tolerate the tight-fitting masks very well. And then they provide guidelines for indications referral to ICU. So if you think the patient is close to respiratory arrest, or the NIV is failing to augment chest wall movement or reduce CO2, also if we are not able to maintain an oxygen saturation above 85%. Another indication is the use of the need for IV sedation or other adverse features requiring close monitoring. So they then they go into talk about the mask. So full face mask, as you can see there on the top, is the what the guidelines suggest. Even though in the UK most places would use a nose and mouth mask in the first instance, and the society suggests that the start of the EPAP of 3 for the reasons that we mentioned, and IPAP 15. This can be titrated according to response. Backup rate. So this is this may be available in some NIV machines and definitely on ventilators. That if the patient respiratory rate goes down below a certain level, the machine will provide some mandatory ventilation through the mask, and they suggested that the rate should be between 16 and 20. IE ratio and respiratory time, I think this is more for mechanical ventilation. We maintain oxygen saturation of 88 to 92, as we said, and the red flags to call ICU or review your action if this pH is deteriorating or the respiratory rate is also not improving. So check synchronization, mask fit, and then consider intubation and mechanical ventilation. On the someone's put in the chat that why is NIV contraindicated in pneumonia? Because what we mentioned is that if the patient with pneumonia without underlying lung disease retaining CO2, this is a very poor sign, and this means that the patient is very close to respiratory arrest, and putting them on NIV will only delay mechanical ventilation. This patient will be mechanically ventilated sooner or later, so it's better to intubate them early rather than late. And the later you wait, the more chance of failure or adverse events as you intubate them. Morbid obese pneumonia, would you use NIV during weaning off the ventilator? Yes, I would use NIV. So if the patient is extubated, and I would extubate him straight into NIV to try and maintain their ventilation and their gas exchange. Thank you for the question. Oh, sorry. So the guidelines also stress the importance of interface choice. Masks have to be fitted properly to the patient to reduce the leak and to ensure good compliance. SATS 88 to 92. Also the guidelines advise that we should not routinely humidify the circuit, but can be considered in some circumstances. Bronchodilators to be used intermittently off NIV in patients who've got COPD. They recognize that some patients will require sedation, but this should only be done in a critical care situation in order to have close monitoring. And also they advise ECG monitoring if the heart rate is more than 120. So these days we can't talk about anything without mentioning COVID. So this is the NIH of the United States COVID guidelines, but their definition of NIV is slightly different to what we've been talking about. So when they say NIV, they mean CPAP or BiPAP. So the NIH guidelines for COVID advocate the use of high flow nasal oxygen or NIV or mandatory ventilation in COVID patients. And when intubation is not indicated in patients, then NIV is the ceiling of treatment. And this is the end of my talk. Have you got any questions? Please type them in the chat.
Okay, thank you so much, Doctor, for an interactive session. So if you have any doubts or any question, please write it on the chat box. So what are the complications that occurs in patient with NIV?
Many complications can happen in NIV. One is a common one, particularly in patients who've got COVID, actually, is a pneumothorax or pneumomediastinum, which we have seen quite often in the latest pandemic. This can also be the case in patients who have got COPD with bulla in the lungs. Patients can get claustrophobic and not tolerate it very well because it's very tightly fitting with a lot of gas going into the patient's face, make them feel uncomfortable and claustrophobic. Also, if they vomit in the mask, this can result in aspiration. And also NIV can give you a false sense of security to the medical team that we're treating the patient and they will be okay. But close monitoring have to be done in order to proceed to intubation if indicated in these patients.
Okay, so we have one more question here.
Yeah.
Please tell us about the treatment of OSA based on AHI.
What's AHI, please? Apnea. Okay. So obstructive sleep apnea per se it does not require NIV. It requires CPAP, and it's usually delivered via a face mask. A nose mask, sorry, when the patient are sleeping using a very small CPAP machine. And it's very effective in treating the symptoms and the sequelae of obstructive sleep apnea. The indications for it in patients who got sleep apnea is that they usually have what we call an Epworth score, which a high Epworth score would indicate that they've got severe sleep apnea. And they will go into the sleep study. If the sleep study suggests that the patients have episodes of a particular number of episodes of hypoxia during the night and waking up during the night and poor sleep quality, then CPAP is indicated in these patients. And if the patients can tolerate it and sleep with it, they tend to improve the symptoms significantly and improve their Epworth score.
Okay, there's one more question. Riles tube feeding and NIV, how to manage?
With difficulty, is a short answer. The problem with the Riles tube is that it will break the seal of the mask, and that will result in a lot of leak and the NIV not being effective. So it depends on your patient. If the patient is compos mentis with a good GCS, you can give them a break every 2 hours, 3 hours to eat and have their bronchodilators and go back onto NIV. If the patient is not able to eat and they're on NIV for a while and you have a feeding tube, then you will have to just accept that there will be a leak and try to manage them this way. Riles tube for decompressing the stomach, again, the same applies. It's even bigger caliber tube and will result in a more leak of the NIV. So, and if this in those situation, this patient should not be managed on a ward. This patient should be managed in ICU with close nursing and medical attention.
Okay. So in dragger ventilator patient should be using CPAP or BiPAP?
It can be dragger ventilators. Or any most modern ventilators these days can provide anything, really. Can provide CPAP, BiPAP, or mandatory ventilation, all the modes of mandatory ventilation, invasive ventilation, I mean. So yes, they can be used either depending on if the patient has got pulmonary edema, then CPAP will be the choice. If the patient has got either post-operative CO2 retention or COPD, BiPAP could be used. And in our hospital recently, we started using our ventilators, proper ventilators in the ICU ventilators in high dependency BiPAP for respiratory patients.
Okay, so we have one more question. So your thoughts on NIV management for COVID, pneumonitis, and exacerbating COPD? Do we keep a high threshold for incubation or do we incubate early?
Thank you for this question. Very good question. The answer is don't know. I think it depends on the patient, and there is not enough literature, as far as I know, to guide us. I think if the patient is retaining CO2 with COVID pneumonitis, I would have a low threshold for it. If they are intubation is appropriate for this patient, then I would proceed to intubate them early. I think from our experience in our trust for COVID patients, the longer you leave them on non-invasive ventilation, the worse the outcome. And if you intubate them early, they may get away with it. And also NIV and CPAP through a face mask, as we said, is not completely benign, and it does result in things like pneumomediastinum, pneumothorax, which we've seen a lot of during pneumonia. If they have a COVID resulting in exacerbation of COPD, you have to think very carefully before you intubate these patients, particularly in a pandemic, because getting them off the ventilator is going to be really difficult.
Okay. So thank you so much for this good question, Dr. Ganga. And any more questions? Anybody, please write it on the chat box. And so before we end the session, I would like to know your 3 takeaways from today's session.
Thank you very much. So the takeaway points is NIV, by which I mean BiPAP, is used for acute hypercapnic respiratory failure, mostly for COPD, and it improves outcome and reduces the need for intermittent mandatory ventilation. One more thing I would like to say for further reading for the audience is the British Flag Society guidelines for the use of NIV 2016 is a very good starting point for the management of NIV indications and considerations. It's an extensive document. It's a little bit old, but it's a good starting point.
Okay, so thank you so much, Doctor. And thank you everyone for joining us in. And thank you so much, Doctor, for taking out time and taking such an interactive session here.
Thank you all for your attention, and thank you for having me.
Okay, and thank you everyone for joining us in, and I hope you all have a great weekend. And I hope you enjoyed today's session and learned something new that you can implement in your current practice. So if you would like to know about an upcoming session, please go on to www.assimilate.in. And thank you everyone. Bye and have a great weekend. Thank you so much, Doctor. Bye everyone.